Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Mariposa Community Health Center for hosting today's session, PCOS in Adolescents with Dr. Debra Cohen. And with that, Dr. Cohen, it's all yours.
Hi, thank you. I'm going to give my own bio today, and I was practicing as a pediatric endocrinology for Kaiser Permanente in Northern California for 30 years. And for 26 of those years, Dr. Pratima Misra was my colleague and partner there. She, however, will not be able to be at the presentation today due to an unexpected but very happy family event that she is attending right now. So I will be doing this on my own. For about the past 20 years, I've been interested in global medicine. I started as a pediatrician for surgical trips on my off time, and I also participated in disaster relief. More recently, I've been involved in type 1 diabetes education in developing countries, and I've also been a MAVEN Project volunteer for the past 9 years, so I was one of the first MAVEN volunteers. And with that, I'd like to start. This is about polycystic ovary syndrome in adolescents. I'm not going to address adult management, which is different in many aspects. And Dr. Misra and I are very available to you all by email at any time, and here are our email addresses. I have nothing to disclose, and as Jennifer mentioned, we are accredited, and physicians will receive one Category 1 hour of CME for this presentation. So the objectives today is that hopefully you will be able to recognize which adolescents might have PCS, diagnose PCOS using evidence-based criteria, understand the comorbidities and other conditions that are associated with PCOS, and help the patient choose treatment options. So now we're going to do some polling. Whoops. And first question. Metformin is a first-line therapy for all obese patients with PCOS. So if all of you can go ahead and start giving us some answers. Okay, just another few seconds. Okay, so I'm going to end the poll. So it looks like 75% of you said that this was true, and 25% said it was false. So the answer is actually false, and I will share some information with you about metformin use as we go further. Okay, I'm going to skip to the third question. Okay, let's see, not able to. Jennifer, can you launch poll number 3? You know, I think we have to go in order. Maybe I'll go ahead and do it that way. Nope.
I can try to. I see the option to go back. So you want me to launch poll number 2 or poll number 3?
Poll number 3.
The one, okay. Yeah, it's not letting me launch it. I have a feeling you're right, probably because you have to do number 2 first. Do you want me to do 2 first and then like cancel it or something?
It's not letting me do 2 either. Okay, sorry about that. Let's see if I can go to the last one. Nope, not letting me launch.
Yeah, I don't know. Do you want me to see if I can get Shirley on?
No, that's okay. We'll just move ahead. I would like to say that for our fourth question, you know what, we will just skip this altogether and keep going, and at least we'll have some information about metformin to share. So this is a photo that I got off of the BBC website a few years ago, and this shows a woman living in England who has fully embraced her PCOS and decided not to remove her facial hair. This is a more typical patient that you might see in clinic who has moderately severe hirsutism in her sideburn areas and under her chin. And you can see that she's removed some of the facial hair from her upper lip and upper chin. And this is another young woman with PCOS who has milder hirsutism and acne. So what exactly is PCOS? It's the most common endocrinopathy in reproductive age women and one of the most common causes of infertility worldwide. We don't know exactly what causes it, but it is due to a combination of genetic and environmental factors that interact. It's characterized by insulin resistance and hypothalamic to pituitary axis dysfunction that result in ovulatory dysfunction, which we see as menstrual irregularities, androgen excess, and a polycystic appearance to the ovaries. It's also linked to a lot of metabolic disease, such as elements of the metabolic syndrome, including high blood pressure and dyslipidemia, also type 2 diabetes and cardiovascular disease. It's also linked to inflammatory conditions such as thyroiditis and other comorbidities such as sleep apnea. So I like this picture from UpToDate because it shows you the cell types that are involved in PCOS pathology. So there's the theca cell of the ovary, the pituitary gland, the granulosa cell of the ovary, pilosebaceous unit, and the adipocyte. And all I'm going to say about this slide, if you look at the red box, is that it seems that perhaps women are born with some ovarian dysfunction tendency. So they have a primary ovarian problem. And then once these women, either in utero or postnatally, are exposed to a particular environmental factor, then their PCOS becomes manifest. Insulin resistance seems to be a key component of the syndrome, and obesity here unmasks or exacerbates this insulin resistance, which then unmasks the ovarian dysfunction and also issues with the granulosa cell. So what exactly happens to hormone levels? And what I'm going to talk about here are estrogens and androgens, and also the role of progestin. So PCOS is a normoestrogenic state, meaning that estradiol levels are compatible with those in the follicular stage of the menstrual cycle, but androgens are high. And because PCOS women are oligo or anovulatory, they don't make the progesterone that comes from the luteal phase of the cycle. And that progesterone allows for synchronous shedding of the endometrium to keep the endometrium healthy. So without this cyclic progesterone from the luteal cycle, the uterus is at risk for heavy bleeding and for endometrial hyperplasia, which can then lead to endometrial cancer. And in addition, obesity, early menarche, and type 2 diabetes are additional risk factors for endometrial cancer. So these women may have other reasons to get it as well. So why is a diagnosis important? Well, it's important because there are gynecologic issues such as infertility. There can be very heavy uterine bleeding, and as I've mentioned, this risk for endometrial carcinoma. And these patients are also at increased risk for metabolic syndrome, as I've mentioned, type 2 diabetes and cardiovascular disease, non-alcoholic fatty liver disease, which is related to insulin resistance, obstructive sleep apnea, thyroiditis, anxiety and depression. And I've highlighted these because I think that we need to pay more attention and screen these young women for anxiety and depression. They often, if they are obese, have a stigma related to their weight, and this can lead to eating disorders. So before we start treatment and counsel about lifestyle changes, I think it would be good to be screening for mental health issues. And we know these young women have cosmetic issues as well. Who is at risk? We know that certain ethnic groups are more at risk than others, and Latinas are more at risk than white or African American women. And genetic susceptibility testing research is ongoing. If women have a family history of PCOS in other women, or women who have metabolic and cardiovascular disease in the family, this would also put them at higher risk. And sometimes also men, such as fathers and brothers, will have components of the metabolic syndrome, diabetes, or cardiovascular disease as well. Of course, if the fetus has been exposed to androgens in utero, then this is going to be a risk factor. And we know that when there is an alteration in fetal nutrition and the fetus is born with perhaps a small for gestational age state, that child is more at risk for metabolic problems and PCOS at later ages. A history of premature adrenarche puts a young girl at risk, as does a history of type 1, type 2, or gestational diabetes. And a high BMI also puts someone at risk, but only 50% of women with PCOS are classified as obese. So we want to consider PCOS in any adolescent with cutaneous signs of hyperandrogenemia. That would include hirsutism, which is hair growth in a male pattern, acne, particularly treatment-resistant acne, and also seborrhea, hyperhidrosis, hidradenitis, and alopecia, although the latter is unusual in adolescents. Menstrual irregularity, of course, is a hallmark of the condition, and you can even have primary amenorrhea. So if you have a young girl who seems to appear physically sexually mature, she had breast development 4 or 5 years before, and she may be either at or near her final height, it may be that she actually has PCOS but has never had a withdrawal bleed, and her endometrium has just continued to build up. Also consider PCOS in those adolescents who have signs related to insulin resistance or who have obesity, and that would be acanthosis, elements of the metabolic syndrome, sleep-disordered breathing, or non-alcoholic fatty liver disease. And if you have a patient who's had a pelvic ultrasound and has either one or both ovaries described as polycystic, this is also suggestive of PCOS, but a pelvic ultrasound is neither required or recommended in adolescents. There's no definitive criteria to define PCOS morphology in adolescents. And what has happened is that many adolescents have polycystic ovaries just as part of normal development, and we don't really know which of those is going to go on to have polycystic ovarian syndrome as an adult. So we don't use this routinely in making diagnosis. It's also true that 20% of adult women can have polycystic ovaries and have absolutely no symptoms. And so we can't make the diagnosis unless the patient meets these criteria. And the criteria come from an international consensus that came out in 2015 and has found to stand the test of time. And so these are the criteria for adolescents. It's going to be an otherwise unexplained combination of an abnormal menstrual pattern as evidence of ovulatory dysfunction. So this is abnormal for age, and it has to be persistent. And generally, it would be preferable if the patient could have these symptoms for 2 years or more. But many times we need to make the diagnosis within the first couple years when there is menstrual irregularity anyway. And the other part of this combination would be clinical or biochemical evidence of hyperandrogenism. And this would be hirsutism, especially if it's moderate or severe. That would be the clinical evidence. And the biochemical evidence would be elevation of free or total testosterone by a special assay. Now, I'm not going to go over this slide, but these are definitions for abnormal uterine bleeding in adolescents, and this is also a chart from UpToDate. So it defines primary amenorrhea, secondary amenorrhea, oligomenorrhea, and excessive uterine bleeding, which also can be a manifestation of PCOS. And when young women are hospitalized for excessive uterine bleeding, a large number of those may have PCOS. So there are a lot of difficulties in making the diagnosis definitively in adolescence. And of course, we know that menstrual irregularity is common in the first 1 to 2 years after menarche, which is why sometimes we're not sure if the menstrual irregularity is a sign of PCOS or not. And hirsutism can be mild early in sexual development, so maybe it will be moderate or severe later, but when we first see an adolescent or teen, it may be mild. As we know, acne is common, and that's why it's not part of the criteria now for diagnosis. And testosterone levels in this age group are problematic, and by that I mean that we don't have good norms for adolescents. We also know that androgen levels get higher in ovulatory cycles. And it's also true that we don't know if slightly higher androgen levels in adolescents actually predicts PCOS in women. And as I've said, polycystic ovary morphology by adult standards is common. So all of these factors mean that it is difficult. And so for those with PCOS features who are within that first 1 or 2 years after menarche, we would prefer assigning that patient a provisional diagnosis of at risk for PCOS, treat these young women, and then reevaluate on reaching gynecologic maturity, which is somewhere between 5 and 8 years after menarche. And that's probably at a time when they can be referred to gynecology or adult endocrinology. So what else is in the differential diagnosis? And I think here we have a kind of a critical point to make, and that is that PCOS becomes manifest usually during adolescence. And so if you have a patient whose signs and symptoms started long after that, then that may be another condition entirely, especially if there's fast progression or abrupt onset of symptoms. So these are the conditions that are in the differential: late onset congenital adrenal hyperplasia, androgen-producing neoplasms such as adrenal or ovarian tumors, Cushing syndrome, hyperprolactinemia, pregnancy, hypothyroidism, and acromegaly. And I always want to make sure that a pregnancy test is part of any and every evaluation for PCOS. So don't forget pregnancy. In terms of making the diagnosis, there are questions that need to be asked in the history and certain elements of the physical exam that should be explored. In terms of history, we want to know the age of menarche, the pattern of menses, the timing and tempo of progression of signs and symptoms. As I've mentioned, something more abrupt may not be PCOS. If there's a family history of PCOS, and if the patient is on medications, there may be some that would mask PCOS. That would be combined oral contraceptives, or something that might bring out signs such as valproic acid. Physical exam, you want to look at the BMI, you want to look for presence of acanthosis, hirsutism, acne, and it's good to do a genital exam because there are patients who might have clitoromegaly, which would indicate a more severe androgenic state and not PCOS. So initial lab testing for adolescents, and I've also listed these in the summary slide too. Total and free testosterone, of course, should be measured. Morning is best because of the diurnal variation in testosterone secretion. Total testosterone is ideally done by a tandem mass spec assay, and I did check, and both Quest and LabCorp have these assays. And free testosterone can be done by a multiple of different methods, and we do recommend that you do not use direct immunoassays for either testosterone or free testosterone. Serum anti-Mullerian hormone measurements have not been verified in adolescents to use in diagnosis of PCOS like they have been in adult women. So we can't use that yet. And patient should be off combined oral contraceptives for 3 months before testing so that the residual effects of the estrogen and progesterone contained in the pills is not in effect. And of course, our patients are going to have menstrual abnormalities, and so we need to do pregnancy testing, as I've mentioned, prolactin, TSH, CBC, LH, and FSH, in addition to chronic disease screening. And the reason why we do so many labs in pediatric endocrinology for this condition is that the patients are really at the beginning of their reproductive lives. And in many, it's difficult to tell exactly what's going on. We don't know if the secondary amenorrhea may be from a hypogonadal state with sort of lowish LH and FSH, or whether there could be ovarian insufficiency or ovarian failure, which might give you intermittent periods and high gonadotropins. And so we tend to test a lot of things at the same time. I've seen a patient who looked similar to a PCOS patient and had celiac disease. And so I think it's good to screen for a wide variety of conditions when you're getting these very young patients, because they haven't had time to declare their clinical course. And in all patients, because of the presence of insulin resistance, we recommend fasting lipids, fasting blood sugar, hemoglobin A1C, and liver functions annually. Again, don't forget to check for pregnancy. And if your total and or free testosterone is high, then we're going to be asking to look at DHEA sulfate, which will rule out an adrenal neoplasm, and the number is significant if it's greater than 700 micrograms per deciliter. 17-hydroxyprogesterone done in the morning will rule out classical or non-classical forms of congenital adrenal hyperplasia. And if the patient looks at all like they might have Cushing's syndrome or Cushing's disease, and 24-hour urine-free cortisol is a good test. And IGF-1 can be done if the patient has acromegalic features at all, and this does happen. I'd like to say that what happens sometimes in these young patients with PCOS is their total testosterone can be normal, but their free testosterone is the one that's high. And the reason for that is when patients have high androgen levels, sex hormone binding globulin is suppressed, and so total testosterone or total hormone levels are low, but free levels will remain high, and that's why it may be good to get both determinations in young people. Virilization is not PCOS. So if somebody has rapid onset or progression of hirsutism, increased muscle bulk, voice deepening, or clitoromegaly, this is going to be frank virilization and not PCOS. So we usually use a cutoff of 150 testosterone level to prompt evaluation for ovarian or adrenal neoplasm. I don't think anyone would fault you for doing this at a testosterone level that's lower, maybe even above 100. It's entirely up to you and depends on your evaluation of the clinical status of the patient. Additional workup, I've mentioned sleep disordered breathing. So it really is good to screen these patients for snoring or apnea while sleeping and perhaps do a sleep study. And please address mental health issues, including screening for depression, anxiety, and eating disorders. I used what I thought was a really good test while practicing. I call it a functional test that's good for diagnosis and treatment, and that's the progestin challenge. If the patient hadn't had a period for 3 months or more, you can use either prometrium, 100 to 200 milligrams at bedtime for 7 to 10 days. I know some people do this for longer, or you can use Provera, 5 to 10 milligrams at bedtime, also for 7 to 10 days. And the patient, if they've had buildup of the endometrium, they should have a period either within a few days before up to a week after stopping the medication. And withdrawal bleeding confirms the diagnosis of PCOS because it means that the patient has enough estrogen to build up endometrium. And this withdrawal also readies the endometrium for the treatment that you're going to be using. So what treatment modalities are best? And I think what you need to do is ask the patient what they are most concerned about, and then design a treatment that works for that. So the best treatment for menstrual irregularity in the presence of hirsutism and acne would be combined oral contraceptives. So this is the first line therapy that we use. All of these combined oral contraceptives are effective for acne and hirsutism. We used to say that certain progestins were not desired because they had weak androgenic activity, but really all contraceptives are okay. They are all very effective for the cutaneous signs. As you know, combined oral contraceptives are contraindicated in certain patients, especially those with a history or family history of venous thrombosis, uncontrolled hypertension, or migraine with aura. And you could also consider the use of estrogen, progestin, contraceptive vaginal ring, or transdermal patch. In pediatric endocrinology, we advise using 30 to 35 microgram ethinyl estradiol preparations. And that's because there has been evidence that using the lower dose pills, 20 microgram pills, is detrimental to bone accrual at a time when it's very critical that adolescents have more bone laid down. And also I found that in particularly obese, very obese, hyperandrogenic adolescents, it was hard to control the uterine bleeding with the lower dose pills, but I had better success with 30 to 35 microgram pills, and very occasionally even used higher dose pills to control the breakthrough bleeding. Limitations of combined oral contraceptives, which you probably already know. There's a higher risk of venous thromboembolism, also stroke and myocardial infarction. And it's somewhat theoretical, but in an adolescent who is still growing, some of these adolescents will have a couple inches to go. There is a risk of growth inhibition by the estrogen in the pill. So you need to at least make this known. And also pills can raise blood pressure. So the best treatment if menstrual irregularity is the biggest issue, you can't use combined oral contraceptives, or the patient doesn't want birth control. So, and sometimes it's one of the parents that doesn't want birth control. So you can use progestin only pills. Prometrium can be used as well as Provera. And also you can use norethindrone acetate, and I've given the doses there. The period should occur within a few days of the end of the course of pills. And you can use, and the norethindrone should also say for 7 to 10 days. And you can use these every other month, and that allows the detection of spontaneous menses. And particularly in patients who are losing weight and who may have resolution of some of their PCOS signs and symptoms, it's nice to know if they are having their own periods in between the use of Provera. And side effects are breast soreness, mood symptoms, bloating and headache. And you have to keep in mind, though, that, of course, these patients have absolutely no contraception, and the use of a progestin-only pill is no help with hirsutism. There also are progestins that provide contraception, such as Depo-Provera, the Mirena IUD, and the Nexplanon implant. And there are other treatments for menstrual irregularity, including the insulin sensitizing drugs such as metformin, and of course, weight loss. So let me go ahead and talk a little bit about metformin treatment. Metformin is only for type 2 diabetes. So if you're using it for PCOS, you're using it off-label, which is fine. And I usually consider it in patients who also have signs of insulin resistance. So they have glucose intolerance or dyslipidemia already, so that I think that they have metabolic syndrome or that they have a tendency to get type 2, and that would be the patient I would be most likely to use it in. We know that about a third of women with PCOS have impaired glucose tolerance, and many will go on to develop type 2. So the thing about metformin is it only works in proportion to the weight lost. It tamps down the secretion of glucose from the liver, and in this way, insulin is reduced, and then androgen levels also are reduced. So it restores menstrual cyclicity and ovulatory menses in up to half of PCOS women. And so you could use it for cycling. However, you have to use it with contraception because these women then could be fertile. And actually, in all PCOS patients, because the anovulation isn't often total, there's always a possibility of pregnancy if contraception isn't used. And there's no impact when you use metformin on hirsutism. It's contraindicated, of course, in certain instances, especially impaired hepatic or renal function. And thanks to Dr. Craig Sadur, who says, start low and go slow. I took this from him. And we start metformin at initial low doses of 250 to 500 milligrams with a meal. You increase gradually by, let's say, 500 milligrams per week. And you gradually increase to a max of 2,000 milligrams total daily dose. And if there is GI upset, you can either give extended release, a liquid form, divide the doses further, and use with food or even after a meal. When someone is on metformin, you need to check yearly CBC, creatinine, and B12. But I would say with metformin, it's not a first-line therapy. You can use it in addition to the other treatment that you've decided on, but it doesn't clearly have a lot of effectiveness in adolescents. PCOS treatment for obesity, lifestyle changes are paramount, and everybody has to be counseled about lifestyle changes. In adolescents, we recommend 60 minutes of exercise daily. And No particular diet is better than another, but healthy nutrition is very important. In terms of medications, liraglutide and semaglutide are GLP-1 agonists that have been approved for those 12 and over. I think they're very good medications and would probably recommend that these be used by or in conjunction with a team at a tertiary care center that has a lot of experience with them. If you are using them on your own, they do have to be used in combination with a very strict nutrition plan and with exercise. And so I think you'd have to be very aware of the entire package of treatment that goes along with using these medications. Bariatric surgery is still a possibility for those who have severe obesity and should only be recommended after a comprehensive multidisciplinary weight loss program. In terms of cosmetic therapy for hirsutism, the least expensive ways would be shaving, waxing, chemical depilation, and bleach. You want to have your patient on an effective form of treatment to reduce androgen levels if you're going to use either laser therapy or electrolysis. Otherwise, you're just going to get regrowth of hair. And these are expensive forms of therapy. They are permanent, although they may not be permanent. The first time somebody is treated, it may take more than one treatment for a particular area of hair in order to remove most of the hair. I would say that laser therapy can be a problem for dark-skinned women because they may have hyperpigmentation. Sometimes they actually get a paradoxical hypertrichosis, and also women who have blonde hair are not candidates for laser therapy. You have to have pigment in the hair, so electrolysis is better for both of those sets of women. Additional treatment for patients with severe hirsutism would be anti-androgens. You can use those at the very beginning with oral contraceptives if your patient has severe hirsutism, but usually we try the oral contraceptives first, and if there's no improvement after 6 months, would start the anti-androgen. Spironolactone traditionally has been the medication used the most. You have to use it with contraception because of adverse effects on the fetus, and it may take up to a year for results. And if you are going to use spironolactone, I think it probably would be good to consult endocrinology because it means that your patient is probably more severe and maybe even needs a second look at the diagnosis. Length of treatment. We don't really know the natural history of PCOS in adolescents. And as I've said, we may need to take a second look once they're gynecologically mature. And PCOS really, for those who have it, it's a lifelong condition. It endures over time. And the optimal duration of treatment has not been determined. And if your patient loses a significant amount of weight, they may actually have resolution of most of the symptoms. So in summary, you need to look for hirsutism, hirsutism equivalents, and persistent menstrual abnormality in order to consider PCOS in your adolescent patient. Fasting 8 a.m. labs may be your best bet to get everything at one time and would include total and free testosterone, pregnancy test, prolactin, thyroid functions, etc., as I mentioned in a previous slide. And combined oral contraceptives are the first-line treatment for menstrual abnormalities and the cutaneous signs of PCOS. And you definitely want to identify and monitor for comorbidities. And you want to look for these in family members too. Other women may have PCOS, and fathers and brothers could have elements of the metabolic syndrome or even type 2. And that's the end of the talk. I used both up-to-date and also recommendations from the 2023 international evidence-based guideline for the assessment and management of polycystic ovary syndrome. It's mainly geared towards adults, but also had some interesting updates for adolescents. And here again are the email addresses for myself and Dr. Misra, and we're certainly happy to answer your questions anytime and to receive consults from you too. I'll stop sharing here, and okay, it looks like okay. Paul Kaplowitz, you have a question. Okay, and I think I've unmuted you. Let's see. Maybe not.
Can you hear me now?
I can hear you.
Yes. Well, thank you for that very complete talk. We struggle with this a lot because, I still do a volunteer clinic, though I'm retired, and I see a lot of obese teens with menstrual irregularities. And I have put a lot of them on oral contraceptives, but there's a lot of resistance among parents because they want a treatment that they could do for 1 or 2 months or 3 months and then stop it and everything's going to be fine. And I try to tell them that, unless there's a lot of weight loss, which is rare, that the periods will become irregular again. But is there any, I know you alluded to the fact that we don't know, but is there any data on, whether, how often periods will remain regular after a 1 year or a 2 year course of OCPs, or is there not really any data to address that?
Oh, that's a good question. I think that, as you said, if there's a significant loss of weight in an obese individual, that's a good time at which you could consider discontinuing the combined oral contraceptives and seeing if there's been resumption of periods. But I don't know any way of predicting whether you can take away that first-line treatment sooner. So it's a good question, but I don't know. I think that natural history of PCOS in the short term for adolescents has not been explored. That's a good point, though. Thank you. Okay, and we have some questions in the Q&A. Can polycystic ovaries resolve? I saw a woman who had a few ultrasound and one said polycystic ovaries and the next did not. Can polycystic ovaries resolve? I'm not, I think in adolescence, the question would be probably yes, because I think that is a developmental thing that can improve over time and is just part of physiologic adolescence. I don't know about adults, but I would assume that not. And I think polycystic ovary syndrome, it is a lifelong condition. And again, you can see polycystic ovaries, but it doesn't mean that a woman necessarily has the entire condition. There's another question. Note that progestin-only pills are good for those not candidates for COCs. Yes, I believe I said that those who couldn't take oral contraceptives could also take progestin-only pills. It protects the endometrium plus provides contraception. Yes, thank you. The only thing it doesn't do is to treat the hirsutism. All right. Are there no progesterone pills possible that provide some contraceptive benefits like we use for women postpartum? Yes, there are. Let's see. I'm going to ask Dr. Lister, who I believe is on the call. Joan, would you like to answer that? And I think we can hear you now.
Okay. I think that you mentioned progesterone pills in a cyclic way,
Yes.
but progesterone-only pills can be taken daily, and that's what you use postpartum. And it also can be used for women who can't take combination pills, providing really excellent contraception and protection of the endometrium, although, as you say, no impact on hirsutism. So yes, use those progesterone-only pills. They're much more acceptable to people than an IUD, and they're easier to stop and start than anything else we have.
Yes. Thank you. And Joan, do you have anything else that you'd like to add?
No, great talk.
Okay, thank you very much. We have another question. TSH has a diurnal variation per up to date. Should we check in the morning too? I have never considered that TSH needed to be checked at a particular time. I think that when it's abnormal, you will find it to be abnormal at any time of day. So I've never recommended that. And let's see here. Is the thyroiditis autoimmune, and should we screen for it? And if yes, with what labs? Just TSH? Yes, the thyroiditis can be autoimmune, and it is checked by TSH. I think that TSH only is a very adequate screening method for autoimmune thyroiditis, because you're looking for an elevated TSH. Without that, you can't make a diagnosis of clinical hypothyroidism. So that would be sufficient. If you find an elevated TSH, you can go ahead and check autoantibodies, particularly anti-thyroid peroxidase antibody. And that would be my recommendation. Let's see. You said exposures can unmask PCOS. What about endocrine disruptors? That's a good question, and I've been asked that before in this talk about PCOS, and I don't know that there's any evidence in particular about endocrine disruptors and this syndrome. Certainly, endocrine disruptors have a role in puberty, maybe even in the advancement of pubertal age, so that perhaps early puberty and early menarche are due to these disruptors in the environment, but I don't know of evidence, particularly in PCOS. There's another comment. In terms of diagnostic testing, I have found a high LH-FSH ratio to be helpful in confirming a suspicion, but experts do not agree on this. What is your view? I think that we are no longer supposed to use a particular LH-FSH ratio in confirming it, and I think that using testosterone and free testosterone in the presence of menstrual irregularities is really all that's needed. Also, I and others have found an elevated DHES to be common in PCOS, but adrenal tumors are rare. So yes, and I agree that I've seen DHEA sulfate levels in the range of 400 to 500, as you have. And that's why we usually say 700 and above is a particularly concerning level. Also, non-classical CAH is not common in this setting, especially in African-American patients. Do you still feel screening for adrenal causes is needed in all cases? That's a good question. I think that is something that I've been used to doing. I'm not sure that you do need to do it unless there are other factors. There may be I think that if you look at the timing of symptoms, if you look for the presence of clitoromegaly, and if you look for other things that make this look like a more severe condition, that's when I would probably do DHEA sulfate and 17-hydroxyprogesterone. I'm not sure that they're needed in all cases, but I think just for completeness and to do this at the beginning of a workup is also reasonable. Okay, so another question is, so to be clear, LH, FSH, and a pelvic ultrasound are no longer recommended. No, I think LH and FSH are recommended. Pelvic ultrasound is not. And LH and FSH can also be useful because you can look for either hypogonadism or ovarian failure. And Dr. Lister also points out FSH is unreliable due to occasional ovulation in women with other causes of abnormal bleeding. However, in adolescents, we can be looking for other conditions. All right, let me see. Do you ever check a fasting insulin level to screen for insulin resistance? No, I don't see any point in doing that. I think that acanthosis is often a very good marker for insulin resistance. I don't see any point in using fasting insulin levels because it's not part of the criteria for diagnosing either prediabetes or diabetes. And let's see, anyone else have any questions? Seems like I have answered quite a few of these that we have. Okay, and let's see, Joan, did you have any other comments? Your hand is still up here.
Oh, I'm sorry. That was about the LHFSH. Put it
Okay.
down.
Okay. Okay, I think that's all of the questions that I have. Whoop, there are a couple in the chat here. Let me look at that. Okay. Okay. There's a question about the 2-hour OGTT. Yes, that is actually a very good test for type 2 diabetes that can be used for diagnosis if there's any doubt after fasting blood glucose and hemoglobin A1C have been done. So I didn't mention that, but certainly to diagnose type 2 diabetes, that's very useful. And as part of chronic disease screening in patients with menstrual irregularities, I do include celiac screening, which is tissue transglutaminase IgA and an IgA level. And we have some information in the chat also about CME survey, so I'll remind you for that. And I'd also like to say that in addition to educational sessions, MAVEN also has consultations available and mentoring, clinical mentoring and leadership mentoring. And certainly Dr. Misra and I, Dr. Kaplowitz, and other pediatric endocrinologists in MAVEN are very happy to entertain your consults. And I've also given you our email addresses. So I think that's it for today. And Jennifer, anything else you'd like to mention?
No, that's it. Thank you so much, Dr. Cohen. It was amazing.
Okay. Well, thank you all very much for attending, and we'll be seeing you again in the future then. Okay, bye-bye then.